All right. Why don't we go ahead and get started? So welcome everybody to our March monthly TEP meeting. Just a quick overview of our agenda today. We'll do a brief update on the caregiver app development, and then go into our primary focus. Again, what these last few TEP meetings have been around the long COVID data elements discussion. So we'll spend the bulk of our time there, and then just cover off on next steps really briefly. So before we dive in, of course, our housekeeping. So transcription is available if you would like that. We do want to remind everyone to use the hand raising feature if you would like to comment. And then, of course, everyone is welcome to use the chat whenever to share feedback. And then just to be mindful of allowing voices who haven't spoken yet to get a chance to speak if you've already shared some initial feedback. We just want to make sure we have a balanced conversation. Okay, so to start off, we'll just give a quick update on where we are with the app development. So just at a high level, so our year 3, this project is in its third of 5 years, build the multiple chronic conditions eCare plan project. So on the right in the shaded box is the specific deliverable related to the applications. So we are building out a patient, a clinician, and caregiver facing application. This is just some of the work we did. So when EMI came on board in October, we evaluated the current interoperability infrastructure. We took a look at the code for the existing clinician app as well as the patient app. And then we have begun building out some prototypes for the patient and caregiver app, which I will explain on the next slide, setting up some testing and then working with RTI and OHSU who are doing the more formal pilot feedback testing for the apps. So this is, since we have been focusing so much on our conversation on long COVID, we did want to just give a quick update on the patient caregiver apps. And so in terms of where we are with the apps, so originally the original thought was to have 3 different apps. However, based on some early feedback and research, and then what has been existing, we've determined that it makes sense to move forward with one common app that has additional behavior changes depending on the role, whether you're the individual receiving care or you're the person giving care. And this new prototype app, I won't get too much into the weeds, but essentially we've reconfigured the backend so that it can be pilot tested with any patient or caregiver who has a health system that is using one of any of the major EHR systems, so Epic, Cerner, Allscripts, VA, and others. So that prototype has initially been built. And then what's next for us is we're working on using some coding logic to use value sets to classify and present data. So if you think of labs data based on condition, that kind of thing, authoring of patient goals, which is critical for patient empowerment, and then also a comprehensive shared care plan. And then we are also looking at some MVP feature builds for the caregiver perspective. So the patient face sheet, for example. And on the right is just a screenshot of our app right now. So very minimalistic, but it is up and running. And so our ask for those of us on the TEP who have caregiver expertise that you would like to contribute, we have 4 ways that we are looking for engagement. So the first is just informing our MVP features list. So we have identified a few features and we're working on prioritizing them right now. And these features are informed by, if you remember way back in November, feels like a lifetime ago, we went through the exercise of prioritizing a literature review of caregiver needs with Marjorie Kelly. And then, so we've been informed by that. We've been informed by the article we shared around on the role of caregiving and the patient's social contexts. And then also just in conversations RTI has been having with their initial pilot testing. And then we've also spoken with Katie Brandt, who is our caregiver TEP co-chair. So that's our MVP features list. And then we'd also love for anybody, if you have interest in doing so, to inform the build for some of our MVP features. So for example, this patient face sheet, Katie is working on just like a bulleted list of data elements that would be helpful to include in any of these feature builds. So after we've prioritized some of these features, would love some thinking from your perspective on how we turn that into a feature. And then the last two are more related to providing feedback on mockups and wireframes, as well as testing some of these new features that we build. So if you're at all interested in participating or getting involved in assisting us with the caregiver app build through any of these 4 ways, one or all, please do send me an email. I would be happy to connect with you outside of our monthly calls. Any questions? And Katie, I don't know if you wanted to add anything to that, but yeah, would be happy to take questions or comments.
Well, I know I'm behind on my face sheet list for you, Karen, but
Yeah.
I just wanted to thank you for, just how incredibly inclusive you're being and thoughtful. And I did speak to one of the caregivers in my support group who said he was also available for any testing. So, that could be helpful as well.
Okay, wonderful. All right. I will move us over to our next agenda item. So long COVID discussion. So this is very much a work in progress, working conversation. I will hand it over to Emma and Gay to just do some framing updates for us before we dive into the spreadsheet.
So Karen, who do you want to start?
Okay, I can actually walk us through this. So this is just the orientation slide. So this is our care planning framework for the purposes of the long COVID data elements gathering. So we've started with health concerns, which includes things like the symptoms list, social concerns, things of that nature. And then we are also hoping to move toward identifying interventions, data elements for interventions. And before we dive in, we do have 2 high-level questions for this TEP that we want to have a little discussion around, and then we can, Emma, if you can, or Gay, to dive into the actual spreadsheet. But this was our first high-level question. Is anyone aware of any surveys or tools that have been developed specifically to assess the impact of COVID, as well as PASC, on a person with that condition, and also caregivers? So this is like a special developed tool for COVID and PASC versus using an already existing tool and applying it to a COVID population.
Mount Sinai might have one. I mean, there are a couple of medical institutions. I think Mayo might have one. But not a, generally accepted model.
Karen, are you considering the ICHOM model?
Karen, you're on, I think you're on mute.
Yeah, I was on mute. ICOHOM.
ICHOM.
Sorry.
And what does that acronym stand for?
Oh, you're going to ask me a hard question.
Post-acute
What is it called?
sequelae of COVID.
That's
PASC?
it.
No, no, the ICHOM. It's patient-centered outcomes measures.
We can look into that.
So you're
Yeah,
talking with respect to tools that they have, or
Well, they have what they call the standard set for COVID-19, which part of it includes instruments, outcomes to be used, clinical, mental functioning, things like that.
so you're saying that you think that they may have COVID specific or long COVID specific questionnaires?
Well, okay, they don't have long COVID. No, I don't think so. I think what they're doing now is they're using their original form with people who have long COVID as well.
Okay, yeah.
It's an international group.
Okay.
I need to check and find out what
I
I.
put the link to their
I
site.
I think it's worth noting that there really are no general clinical guidance that exists. We helped advise the CDC on the interim version that was published the beginning of June of 2021. It's March of 2022, and there's not been an update.
Okay, but this instrument isn't about care. It's related to this
just the
question
impact,
one.
yeah.
Did they come up with a measure to look at the impact of COVID?
What kind of impact are you looking for?
It's a broad impact question. Sorry, Carla had her hand raised, but yeah, it's an open-ended question.
Hi, Karen. Thank you. Sorry. I don't know if this is directly addresses your question, but I had just sent over to you a little bit late, sorry,
Okay.
for this meeting, a list of data elements that are being collected by the Project Post-COVIDity, which is a project of the FDA Oncology Center of Excellence to understand rates of infection in patients with cancer and subsequent therapies for COVID or current therapies for cancer. So I don't know if it sort of speaks to data elements needed to identify that in a infection in a cancer population and what treatments they've been using, as well as how that might have affected their cancer treatments. I don't know if that answers your question.
Yeah, this is helpful and more than enough for us to get going. So yeah, we appreciate everyone's, and thank you, Gay, for finding the Leeds University link. Okay, yeah, if anyone comes across anything, I think it would be helpful, but this group is probably the most helpful to surface any whispers of such a tool. So
I just put a link to the a Pink Sheets article on this Project Post-COVIDity in there, so it gives you a sense of what it's about, and that'll help you give you some framing for the data elements I sent in.
okay, perfect, thank you. And here's our second question, and I'm gonna actually ask Gay to walk through that question.
Well, this is talking about diving into detail. This is, you'll see, actually, I think we can ask the question, and it's something we actually brought up last time, but when we have something that, for example, cognitive impairment and anosmia are both symptoms / conditions that have been associated with long COVID. When we are building terminology lists or concepts that will be in the set that we're going to be looking at in the project, sometimes you'll find codes such as the first one there, which is cognitive impairment due to something. And the example there is multiple sclerosis, or a type of condition that's been, existed, that's definitively associated with another condition, such as this, the anosmia is, congenital anosmia is, they haven't been able to smell since they were born. So it's just a high level question, and not really wanting to get into details of a bunch of different codes until later, but in general, do you all feel that codes that are due to something specific, some other condition, or a condition that's specifically named that implies that it's been around for a while or is associated with another condition, clearly associated with another condition that a patient has. Looks like Jenna.
Jenna.
So I just,
Yeah.
yeah, I'll just make a quick comment because this probably sounds like a sort of a strange question. So I just want to give a little more context. So I think the reason why we wanted to bring this up is because, at its heart, we're trying to develop a care plan for people with multiple chronic conditions. And so if we were to create a value set for cognitive impairment that excluded cognitive impairment due to multiple sclerosis, then it wouldn't be useful in that context, if that makes sense. And I think ultimately, if we start to create value sets that start to get too narrow, then we will get to a place where it will be sort of impractical to implement, or at least that's my concern, right? So like if we have like a cognitive impairment due to COVID or potentially due to COVID, where we X out, codes that say they're, cognitive impairment due to multiple sclerosis, and you could do this for any sort of symptom, then it's not useful in a broader multiple chronic conditions context. It's only useful in this sort of COVID context. And I'm not sure that that's a good long-term strategy in the context of multiple chronic conditions. So hopefully I made this question a little bit more clear and not more confusing by those comments, but I just wanted to give that context there.
Okay, yeah, no, I totally agree with you about having sensitivity as opposed to specificity, but getting down to where it's if we are going to use the value sets in say filtering or CQL to pull terms into the app, or finding patients that have this related to COVID, then terms like this give me pause. And as opposed to, other than that, like I agree that all other, very, very much having sensitivity as opposed to specificity is important. But if the TEP agrees that, we should definitely include them because we don't want to miss folks. I totally get that. And, we just have to make sure we describe in the metadata what the scope of the value set is.
Yeah, and plus I would also wonder, a lot of patients have previous conditions, like fibromyalgia, for example, has a cognitive impairment that's called like whatever, fibrofog or something else. And yet they will feel like they get worse after they have a COVID illness. And so I think how does one document that will change depending on the clinician, right? Like, so if the fibromyalgia clinician is seeing the patient, they will call it a fibroflare, and yet it's in the context of the worsening after COVID infection. And so I just think it gets a little contextual too. Okay, so it does sound, I'm happy to hear with additional people, but it does sound like this is definitely the way we want to go, because we, I think that, Luca, that's a great point you make, is that, clinicians tend to be very focused on their specialty, and they're probably may not be willing to add another fibro, fog, another sort of fog thing when they're not sure that it's not the same thing or whatever, but it's still important to note that this thing flare is worsening. So I think I'm understanding. Yeah.
I think another potential scenario where it would be good to be inclusive of these codes too is that, cognitive impairment, I think, is a really good example that you guys picked, I guess, kind of by accident, because even if the cognitive impairment isn't due to the long COVID, that would affect somebody's ability to manage the other symptoms that did come from their long COVID, right? So if they had cognitive impairment pre-existing from MS, in addition to COVID potentially exacerbating it, it could also just make it harder to manage the other set of symptoms that were directly due to long COVID.
Got it. Yeah. Cool. That we have a way forward, and it's actually a lot easier. So I think that's great, and what you're saying definitely makes a lot of clinical sense from a multiple chronic care condition perspective.
Kevin, and then Diana.
And in response to that question, I would say it perhaps is too early to make a judgment as to whether symptoms are caused by PASC or not.
Right.
We probably just don't know.
That's right.
Diana?
First of all, I would actually dispute that because working off of patient-generated data of real-world evidence on hundreds of thousands of patients, there are definitely clear markings of COVID, and specifically the neurological piece. But before that, I wanted to just add in that we are having members actually being diagnosed with early onset Alzheimer's, early onset dementia in their early 40s, and we're seeing more and more of it.
If I could just ask a follow-up question. So this project is probably not the way to find this out. But your point about the large numbers of patients for post-acute PASC symptoms is taken, but follow-up still, of course, has been relatively brief. So I would just put forward, for the group that follow-up is still very short, clearly, and there may still be more to learn about which symptoms are ultimately determined to be related to PASC or not, but that's up to the experts who determine those things.
All of that phenotyping's already been accomplished. It's already finished.
Okay, so I just want to move us along to discussing the actual data elements that we do have. Just for your reference here are all the pieces of documentation and feedback that we have received to date. So thanks for those of you who have shared with us. And Diana, we have sent you a few emails because we are eager to see the references that you have pulled. So if you're able to send that to us.
I'm so sorry. Can you resend it to me? I was traveling and we have a tiny team. I did remember, but it got lost somewhere.
Okay. Yep. I will
That'd be great.
resurface
And
that.
we can get it to you, and we can get that information to you.
Sure. Thank you. So for reference, this is what we have included. And Emily, I will note that we're still in the process of incorporating the feedback that you have collected from your team as well.
Thank you for that. No, and we were a little late, so I totally understand and appreciate that. Thank you.
All right. And so Emma, I will hand it over to you. Are you able to share your screen, or do you want me to pull it up?
Yeah, I can share my screen. Thanks, Karen.
Okay. All right. Thank you.
So hi everybody. I'm gonna go ahead and pull up. Sorry. Let me make this bigger. So I can share my screen and pull up the worksheet that we shared the link with folks during the last call. Can you guys see my screen okay? Do you see an Excel spreadsheet, or am I sharing the wrong screen?
We see an Excel spreadsheet.
Okay, all right. So this is the worksheet that we posted, or we provided the links that people can either come in and directly review the sheet, add stuff to the sheet. And also as we receive emails from folks, we've been updating the sheet with information that people have been sending us. And also as we've been finding, through our own research, we've been adding things to the sheet as well. So this is our working sheet, for lack of better words. Karen, I'm on the right sheet, right?
Yep.
Okay. All right. So when we left off our last conversation, I know we did get from Aluko and I hope I'm saying your name right, and I apologize if I'm not. Some like immunologic changes, but you added in et cetera. Was there anything specific? And we can look a lot of this up, that you or elder folks on the call in regards to immunologic changes, like, you know, frequency in infections, increases of allergic responses or intensity of it also, and all of these fears about response to vaccines. Anything else that we can add to this under immunologic changes that folks have come across to help us? Anybody?
Like low level autoantibodies sometimes will show up on labs that become kind of sometimes hard to interpret, you know, like whether it's a low level ANA or a low level I'm blanking on it right now, but like hypercoagulability states, those kinds of things can show up sometimes on the laboratory testing, which might just be over diagnosis sometimes, but it then has to be interpreted.
Neuro long COVID has been associated with a dysfunction in T cell production.
All right, Emily, you had your hand up too.
Thank you. Yeah, I was just pointing out to some of the immune cell metabolism that we find altered in ME/CFS, and that might be replicated also in long COVID. So the metabolic changes that you see in immune cells, and also in other cells as well. Natural killer cell function is also one we see very often. And I just added a link to the NIH study on that in the chat just for reference.
All right, and we are recording this call, so if I don't type everything in there, we have the recording. I can go back and listen and get that out of the call just to let people know. Anything else? Okay, thanks, good. Thanks, everybody. Another area we had asked some questions on, like how detailed did you want us to get when it came to rashes? So we did do a little bit of research, and through some of that information, I was able to pull out things like pustular rash, erythema, urticaria, these types of things. Is this detail enough? Do you want us to get, you know, are you seeing anything else, anything more in context of rashes?
COVID bumps is a big thing.
What are COVID bumps? Can you describe those?
We have pictures on Survivor Core. So the imaging is pretty extraordinary, specifically for the dermatological issues, and pictures of COVID toes and all that stuff. There's a lot of people uploading their photos to get other people's input. And the rashes are really, really terrible. It's not like a little eczema.
I should put eczema. E-C-Z-E-M.
Diana, do you have any sense of what these are getting, like, if at all, getting diagnosed as? Because I would speculate that there may not be an existing data element or state data code, like an existing code from a common clinical terminology for COVID bumps. I mean, there may be, and maybe there needs to be one created.
So
but do you know?
We have the chair of Mount Sinai's dermatology department on our board, who's a physician scientist and invented Dupixent. So I can find out from her, but truthfully, of all of these things, I really think that they should be evaluated in order of the amount of human grief and suffering that is being caused and the suicides that are coming, and that's not starting with dermatology. chilblains, but I don't think that's dermatological. That would be more of a blood clotting issue.
Which one was that?
I think she's responding
Chilblains,
to what?
COVID toes, is a clotting issue, not a dermatological issue.
Like TOES? Okay, we can look this up. All right. Then another question again goes to, and I'll open this in another window, hopefully. Can I go to another window? Oh, yes. This is in SNOMED, and when we look up rash, of course, rash has a lot of children. So we see a lot of these, and when we go to codify, like necrolytic stuff. So we, back to the question Gay had asked earlier, we had discussed earlier, secondary forms of things. So we think COVID does exacerbate some of these. So we will also go through this list and look at including these kinds of things in the list of symptoms in relationship to rash. All right. So, and we did take a look at some of the assessment forms that the assessment scales that were sent to us. We have links in here to those, the ones that we could find. And some of them may be proprietary, like the PASC Sim. Do you guys know if that is proprietary? Anybody? I think it's Henry.
Yeah, yes, you have to get
License.
approval.
Yeah. And then there was also this dyspnea scale. I think Dr. Dorr has sent that one in. So I'm assuming that might need special approval for that as well. Any other assessment scales that people can think of? I know we had, we've been putting, but you guys have been putting bunches of resources in our list. Yeah. And there were some that we did come across. There was one that had to do with assessment and testing that came from CDC. Anybody come across these where there's a list of various lab testing? So when we get to the intervention and testing, we're probably going into more details and talk about some of these. But there are different other types of assessment and testing tools as well, like the functional scale, PCFS. That's the promise one. We already have that one on our list. So we have links, or we will add this to the spreadsheet. So if anybody want to go through and take a look at some of these and tell us, if they've used these, and maybe we can just go ahead and include those as well.
Some of the challenges with the post-traumatic stress surveys, often that they're like sort of very localized to like a particular event, like a traumatic event. And a lot of the COVID patients are having like an experience that's traumatic, sort of like a prolonged experience. And so that's just something to keep in mind.
Can we go back a second to the issue about rashes?
Okay.
I didn't get a sense. I was multitasking, putting something in the chat. So are you suggesting we actually use all those categories, or just use the big category of rash and work from there?
So we started off with the big category of rash. People can say generalized rash, localized rash, that kind of thing. And then we're also saying that people, can actually go more specific to say the kinds of rash, like the fascicular rash, or erythema, pustular rash, those kinds of rash. Rash associated with fever. I think that's what sweet syndrome is, you know. And if there was a rash associated with transfusion that is exacerbated by COVID or something, then that's also included on that list. And then in SNOMED, and this is what we were pointing out, they also under the parent of just generalized rash, there's also these more specific rashes that can also be used as well.
And so we can't just say rash because we'd be missing a lot, because clinicians will be documenting using these kinds of terms, but they are all rashes.
Okay. Thank you.
Well, I know when it comes to symptoms though, I don't know, maybe it's just me thinking, you know, with my EHR hat on, my head on or whatever. Typically patients report symptoms. Would a patient just specifically describe it as rash and the provider agrees with them and just continue, you know, in that general sense? I don't know.
I mean, couldn't it be both, right? Sometimes people know a lot of details about what they have or what they're, you know, experiencing, and other times they might just say rash. But the point being is that we, again, want to be sensitive as opposed to very specific.
Yeah. All right. So I made a note of grief and suffering. We'll do some more look up and research around that in context of long COVID. And we'll be looking up COVID toes. And we will share that assessment scale link from CDC. I'll put it in the document for the lookup purpose. And then we started to go into any other thing on any other parts of the symptom list. I think, Gay, you have added some additional symptoms we found, or you know, that we may
And
not.
this is some of the information from Emily that we were still yet incorporating. I think we've got about 10 or 11 more terms in this list than is on the purple list so far. It's from Emily's terms and from oh gosh, sorry, I'm forgetting which place where I pulled the some additional information from.
The GitHub.
No, actually, maybe it was that. Yeah, that's a really huge long list. I found this interesting resource actually. Came out of Boston Children's, and not just Children's, but the whole conglomerate up there, where they actually did a query in the
EHRs.
Directly in the EHRs of anything that anyone said about themselves with respect to long COVID, and including the frequency and the commonality in the number of terms that they found. So we're looking at that and bringing those in that are not already on our list.
Yeah, Gay, there was this article that we were talking about this morning, right? This is like the top high level 50. I think they found like 300 and something different symptoms.
Mm-hmm.
They pulled up that's another resource that we're also looking. Now we have many of these, and I think that was maybe we have many of these on our original list, but there were some things I noticed that we didn't have, like weight loss. Yeah, we didn't have GI symptoms. Those kind that stress.
We're seeing Parkinsonian like tremors, neuropathic pain that's so severe as mimics advanced diabetes, inner vibrations that would normally be classified as akathisia but are not medicinally induced, COVID onset diabetes, COVID onset lupus, tremendous issues with loss of teeth, tinnitus, for starters.
Okay,
I think I picked up
you.
some of those tremors and vibrations in that.
Yeah, in the other list.
We just published a paper with Yale on that a couple weeks ago on the Parkinsonian-like tremors and feelings of inner vibrations.
Okay, thank you. So in the interest of time, I just want to move us down to, we added a category here for comorbidities. So Emma, when you're done typing that, if we can just scroll down to that. And then, so we'll just discuss comorbidities for 5 minutes, and then we do want to just head over to the interventions piece just to make sure that we're clear on homework, if you will, for March. Okay, so these are the comorbidities that have been showing up. So Luca, are you adding obesity?
Yeah, obesity is super helpful and important because I mean, it in terms of energy conservation and activity planning, it's like really important. And then it would be helpful to have some frailty construct, whether it be debility, I think is an ICD code, because again, that's something that's very helpful in terms of energy conservation planning, and even for the cognitive impairment planning when you see a patient who's very debilitated before their COVID illness.
Just to note, the long COVID generally affects the youngest, like young, healthy people the most.
Well, so far, I think that the challenge is that a lot of older people may present later because they kind of might ascribe a lot of their symptoms to something else. But when they do come in, it gets even more complicated to treat them.
Also, as survivability gets better, I wonder if we'll see more symptoms in older folks. Frailty is an element that we have on our multiple chronic conditions data set anyway, so it's going to be on our ultimate compiled list anyway. But
So is it safe to say that the comorbidities list is inclusive of all the comorbidities that CDC defined for being at higher risk for just getting COVID, and then having potentially additional comorbidities that are associated, that are affected with long COVID, as opposed to the original list, right? I would assume that all of those are on there, but then there are additional ones.
Well, in GI, functional GI disorders like irritable bowel syndrome and functional dyspepsia can be exacerbated during COVID. And also, we're waiting in GI, we're waiting for, there's some data that suggests that viral infections and other sort of infections years down the road can bring on these disorders. So we're kind of waiting for an increase in functional GI disorders in patients who have had COVID. We've already seen that in some of our literature and some of our studies.
We're seeing that a lot of the GI issues are related to an assault on the autonomic functioning.
Thank you for mentioning the autonomic functioning. I just wanted to add POTS and other types of dysautonomia that we're seeing as common comorbidities or
I wouldn't
showing
call it
up after.
I mean, we're seeing it as a direct result of COVID, and it's one of the most reported symptoms. It's sequela.
And I'll just echo what I said in the chat there, and also add MECFS, which we have multiple reports of folks being diagnosed with MECFS following their COVID infection, MCAS, mast cell activation syndrome, and EDS, Ehlers-Danlos syndrome, or other hypermobility disorders. We're noticing that a lot of folks who had EDS prior seem to be more likely to exhibit long COVID symptoms. Again, that's anecdotal data, but that's definitely a lot of the reports we're getting.
Yeah, and just to reiterate, I think, although I think POTS is a big component to what we're seeing in long COVID, there are people who have had POTS before and then have an exacerbation after their COVID. And so it's helpful to have it as both. a comorbidity and part of the syndrome versus symptom complex. Same with MCSS. A lot of the patients, MCAS, the patients who have MCAS will tell you that their long COVID symptoms basically mirror, you know, their MCAS diagnosis, workup, and things like that. So, you know.
Yeah, and just I think where we put these data elements for now isn't ultimately going to be that important, because really we're not. I think in the final presentation of these, we won't necessarily be saying like this is a comorbidity and this one's a consequence. We're creating data elements, and I think these headers are more to help us think them through and come up with ideas than they are to like make a statement about the etiology. I think these are just pieces of information that we want to be able to track so that we can help come to a better understanding of, you know, what's caused directly by the COVID infection, what might be caused by hospitalization associated with COVID, what might be, you know, so we can parse all of those like little nuances out. You know, so I wouldn't get too hung up on whether we call it a comorbidity or a consequence at this point. I think it's just about getting the data elements on the table so that we can include them.
I agree. Don't get too hung up.
Thanks, Jenna.
If you want to give us more information, then we'll take it.
Yeah. All right. So Emma, if you're okay, I think let's just hop over to the interventions tab.
Okay.
So we can kind of explain the next group of data elements, if you will, that we're collecting. So here we are looking toward interventions. And so again, just like helpful prompt headers, if they're not helpful, don't worry about them. But we have labs and results. And then in terms of treatments, we've kind of at a high level just broken it down to like medications, therapies, and education. And so for March, we are looking for you all to share any documentation of any kinds of interventions for long COVID that you've heard about or are employing yourselves with, for these health concerns.
And please don't let our little section description thing right here restrict you in any way. We want you to add, you know what I mean? Like if you think of something else that may not be in these 4 buckets, or if you feel like we need to have additional buckets, please definitely add that. And if you feel like our buckets need to change, please change them. You know, you guys have access to this.
Yeah.
There is, I don't know if this is relevant, but there is some research suggesting that vaccination could decrease the length of the duration of long COVID and sometimes even stop it altogether.
Those studies haven't been longitudinal, so we don't know if any of the relief found by the vaccine stays, but it is a good clue. And we're doing research with Dr. Iwasaki at Yale, doing autoantibody assays before and after the vaccine to figure out why there is some symptom relief found by many.
Yeah, this is Hector. Let me know if you come up with something. This is something of interest to me.
What was the thinking of the education category? I mean, I want to just understand a little bit about where, because it feels like sometimes like therapies are often mixed in with patient education. So I'm just trying to understand what your thinking was there.
Typically, if you do mix it in, like we're saying, we're not trying to make you separate them out and, you know, don't overthink it. You know, like as Jenna said, we're not forcing you into using these boxes. If therapy and education usually go together, then just ignore the education and put whatever therapy indication there is. And we can add it together if you guys want us to do that. Just put therapy and education in this and get rid of this whole thing by itself. If this is causing confusion, would that be better?
No, I mean, I'm just asking. I think it might be more self-management, or I don't know if there's a better term, but it's just, I think you're onto something. I'm not sure if it'll be obvious to.
How's that?
I would agree. I agree with that.
Okay.
I do think it's just saying education is confusing.
Okay. Or maybe I should say patient education or something like that. Would that be better, or is that even worse?
You can leave it like that for now.
Yeah, but I also think we need an example of what you're thinking of. In my experience, that isn't what we're not doing. We're not, people at my institution, they're not really using education, or at least I don't think of it as education.
So I think this heading is a holdover from our MCC, our multiple chronic conditions data elements. And I think it's easier to think of examples like in diabetes and kidney disease where we started, where it would be sort of like, like sort of centered on self-management education, but things about sort of, how to manage diabetes in your day-to-day life, sort of portion size education, how to read a food label, like that kind of education, I think is where this came from in the multiple chronic conditions realm. I don't know how that translates in the context of COVID, because we know so little, or we're still learning so rapidly. It's probably hard to have as much education.
No, it's super important actually. And if you want to hear me talk, that's like probably 90% of what we need to do. But it's just that I think we don't get paid for it very well. And so we typically we integrate it into other things, whether it's the clinical visit or the physical therapy visit. So that's just practically how we end up doing a lot of it. But it is probably a big chunk of what's needed. So it's helpful that we have it. But
okay, and Rachel.
Sorry.
Well, that's actually a good lead into what I was going to ask, which is, and I don't want to get like ahead, but thinking in terms of maybe more like policy changes or interventions that would be like a policy change. Like, for example, I'm thinking on the behavioral health side of things, either payment policies or policies like, time off from work, or thinking ahead to make more major policy changes. Are we ever going to get to that? Or is that outside the scope of what we're looking at? Should we maybe dial those back and try to think of them as interventions at this step of the game? I'm just curious about the plan.
Should we call that social, right? Things like time off work.
No, yeah, that's a big call out. That's a great call out because, in this particular space, the disability evaluation is actually quite complex because patients maybe can do something, but then they will go home and crash and they'll crash for 3 days. And so how do you quantify that in a way that allows them to actually get the time off work? And that's actually hard. So we do need some help in terms of how to construct that.
Jenna?
Yeah, I was just going to say that's a really good question. I think maybe one way to frame this is like, I think we don't necessarily need data elements that get into like capital P policy changes. Like, I think we want to think about interventions that are going to be performed at the given that this is electronic health care, care plan delivered, the care plan is going to be centered around an individual person. So the interventions should be sort of the interventions that you could do on an individual person, which is not to say we shouldn't go into the social realm. I think we absolutely should. And, if time off work is an intervention that the patient needs to have, I think that makes sense. But I think where is very, very important, and I hope there are folks working on it, but it's probably outside the scope of this specific project where we're coming up with like data standards, is those policies that would be conducted at more of a population level. Does that make sense as a guardrails?
Yeah, that's helpful. Thank you, Jenna. I was thinking kind of also at the individual level, like I put it in the chat, like a referral to Social Security for, like something not changes to the SSI process, but trying like a policy intervention of trying to link the person to the services. So it is
Absolutely.
almost like the what's the
Social
word?
medical integration type of
Yeah,
stuff.
like the prescriptions for food kind of model of things.
Absolutely, yes. Those I think we should include. And we do have some already from our multiple chronic conditions list too, but I think it's good to brainstorm and add to that anything we might be missing.
Something else, what about eligibility for disability compensation? I know it's a complicated subject and maybe not very relevant, but
I would include that. I think that's good. Thank you, Hector.
Okay. Karen, stop.
All right. Okay. So in the interest of time, oh, go ahead, Hector.
yeah, going back to symptoms, to that previous, yeah, the data elements. Do we want to include what they call brain fog or confusion or difficulty in concentrating, things like that? Is that included?
Yeah,
Oh, yes,
that's
perfect.
there.
Thanks.
Mhm.
Thank you. Yeah.
Okay.
Because that would be the basis for disability compensation. That's why I wanted to have that
Yeah.
for consistency on
Makes sense.
completeness.
All right. So I'm just gonna grab the screen back from you.
Okay.
So thank you, everyone. This was very helpful. So in terms of next steps, we are looking for any additional, both like COVID interventions and if you have any feedback on health concerns. So the symptoms list, the social concerns, related social issues, as well as comorbidity. So any feedback on those, feel free to send, but we're really looking for any documentation you have on interventions. And as always, feel free to just forward us whatever you have or use the data element gathering spreadsheet. And then the second one is to just email me if you want to be involved with any aspect of the caregiver app build. Our next meeting in April will be on the first Tuesday of April, so that's April 5th. And thank you all so much for your time.
Thank you.
If I can,
Thank
that
you.
last message about
Thank you.
exercise.
Yeah, I'm putting it in there right now.
No,
Yes.
I would just add that for most people they have exercise intolerance, and there are benefits to moving around and not letting what you can't do get in the way of what you can do. But exercise is like straight out exercise is not being recommended.
Okay.
Thank you so much.
All right. Thank you, guys. Thank you so much. This is my favorite time of the week, to be honest.
Bye.
Goodbye.
Bye.